Not every mature cataract with phacodonesis can be managed with routine phacoemulsification. In eyes with severe zonular weakness, the real challenge is recognizing when to stop trying to preserve the capsular bag and instead transition to a safer, more predictable surgical strategy. In this video, we demonstrate the management of a 30-year-old male with a mature cataract, marked phacodonesis and iridodonesis. The surgery begins with the creation of partial thickness scleral flaps. Although this appears to be a straightforward step, the success of the glued IOL depends on it. Asymmetrical or thin flaps can make haptic externalization difficult and compromise long-term IOL stability. Careful planning, uniform flap depth, and proper positioning provide the foundation for the reconstructive phase of the surgery. An anterior chamber maintainer is then introduced to maintain a stable anterior chamber throughout the procedure. Chamber instability or inadequate infusion can increase stress on already compromised zonules, making every subsequent maneuver more challenging. A controlled capsulorhexis is then initiated using a cystitome and completed using a rhexis forceps. In eyes with severe phacodonesis, the capsule tends to move with every instrument. Trying to complete the rhexis with excessive traction can propagate zonular dialysis or extend the capsulorhexis. Gentle tissue handling can help avoid these complications. With extensive zonular weakness, conventional phacoemulsification is no longer the safest option. Rather than persisting with an unstable capsular bag, the procedure is intentionally converted to a planned lensectomy. The nucleus is then prolapsed into the anterior chamber through the sclerotomy. Before manipulating the lens further, a meticulous anterior vitrectomy is performed. This is one of the most critical steps of the surgery. Even a few residual vitreous strands can transmit traction to the peripheral retina, increasing the risk of retinal breaks and making subsequent maneuvers unsafe. A thorough vitrectomy creates the freedom to safely manipulate the nucleus without vitreoretinal traction. An intraocular lens is implanted beneath the nucleus, creating the Agarwal scaffold, which provides a stable platform for phacoemulsification while preventing the nucleus from falling back into the vitreous cavity. This simple concept transforms an unstable situation into a controlled one. However, the scaffold is only as effective as its execution. Inadequate vitreous clearance, improper scaffold positioning, excessive phacoenergy, or poor chamber stability can destabilize the nucleus and increase the risk of endothelial trauma. Adequate viscoelastic protection, controlled fluidics, and gentle emulsification are essential for a safe outcome. With the nucleus safely removed, attention turns to glued scleral fixated IOL implantation. This is the reconstructive phase of the surgery where precision matters more than speed. Symmetrical scleral flaps and accurately positioned sclerotomies lay the foundation for a well-centered IOL. The leading haptic is gently externalized using the handshake technique, followed by the trailing haptic, taking care to avoid excessive manipulation that can kink or fracture the haptic. Each haptic is then securely tucked into its respective intrascleral tunnel, creating stable sutureless fixation. A shallow scleral tunnel, inadequate haptic tuck, or asymmetric fixation can result in postoperative IOL tilt, decentration, haptic slippage, or late dislocation. Before concluding this step, confirming secure haptic fixation and perfect centration is essential for long-term stability. The procedure concludes with the single-pass 4-through pupilloplasty. The iris is gently grasped with microforceps and a 10-0 polypropylene suture on a straight needle is passed through the proximal iris. A 26 or 30 gauge needle is then introduced through a clear corneal incision, passed through the distal iris, and used to railroad and externalize the straight needle. A Sinskey hook is used to create a suture loop through which 4 throws are made to fashion the characteristic single-pass 4-throw self-locking knot. Gentle tightening of the suture brings the iris leaflets together, creating a round, well-centered pupil. The knot lies flat against the iris and the suture ends are trimmed, completing a secure iris reconstruction with minimal tissue manipulation. Complex cataract surgery is rarely about following a fixed sequence of steps. It is about recognizing when the surgical plan needs to change, anticipating complications before they occur, and adapting the technique accordingly. Every maneuver in this case is guided by one principle: respect the tissue, stay ahead of the complication, and always choose the safest path forward. Thank you.